Hello, I'm Dr. Lalit Shimpi. I'm a consultant gastroenterologist and hepatologist at Pune, practicing for the last 15 years, and I'm attached to Jahangir Apollo Hospitals as the Chief Therapeutic Interventional Endoscopist and also attached to Dinanath Mangeshkar Hospital. In this talk, we'll discuss a bit about Delhi from anti-tuberculosis treatment. Most of the data from India shown us that the most common agents in India which cause drug-induced liver injury or DILI as we call it in short is because of AKT or anti-tuberculosis treatment. Tuberculosis, as we know, is a chronic infection of a global health concern due to the high incidence, and we see a lot of patients with tuberculosis. There are people also who are on second line therapy because of drug resistance and on modified therapy because of co-infections. Generally, the agents that we use for treatment of tuberculosis are four. So, isoniazid, rifampicin, pyrazinamide, and ethambutol. So, the most common out of these causing drug-induced liver injury is isoniazid rifampicin combination. Pyrazinamide is also equally hepatotoxic, so one has to stop these drugs first when any patient comes to you with anti-tubercular drug injury and presents to us as hepatitis. DILI is major adverse events of anti-TB treatment, and it leads to a lot of non-adherence because patients don't tolerate it or there are treatment failures. Overall, if we have more wider outlook, development of drug resistance is also common because people don't adhere to treatment because of various side effects. However, generally, if one starts people or patients on tuberculosis treatment or AKT or anti-tubercular agents, especially these four, it's important to monitor these patients. I don't prefer doing routine liver function tests in all patients who have been started on AKT because some amount of mild transaminitis is known, and if it is asymptomatic and it settles down on its own, really nothing needs to be done, and you don't need to stop the AKT. But what I generally tell my patients is whenever they start AKT to report back to the doctor in case there are some new symptoms such as anorexia, loss of appetite, nausea, dyspepsia, or fatigue or weakness. So, if the patients develop any of these symptoms, I think they should report back immediately to the treating physician. Generally, most AKT-induced hepatitis is seen quite early, within the first week or so, and some people do come a little later, say at about 2 weeks or 3 weeks also. But most of the times, in a few days after starting the AKT or within a week or 2 weeks, most of the people will present back to the physician with symptoms and signs of drug-induced liver injury. The clinical manifestations of anti-tubercular drugs are generally diverse, they are non-specific, and as I said, many of them can be asymptomatic or they may have mild symptoms, some of them may have severe symptoms, and there are some patients, especially who have continued the therapy despite developing symptoms, might land up into acute liver failure. If the patient is asymptomatic, you have mild transaminitis, and if you pick it up, but it is significantly at a higher level than what you would expect, then one should stop the AKT and restart it at a later time when the enzymes have normalized. However, which patients they will develop anti-tubercular agent-induced hepatitis and who won't is something that cannot be predicted. Probably it has some genetic or immunological reason, and there is no really a fixed relationship between the clinical and biochemical parameters of what happens to these patients and why they do develop hepatitis. But it's important not only for anti-tubercular agents but also for other non-AKT drug-induced hepatitis to really classify these patients as to whether they have a hepatocellular injury or a cholestatic injury or a mixed type of injury. So if you have someone who comes to you with drug-induced liver injury and their ALT levels are more than 3 times the level of normal, then it's predominantly hepatocellular injury if the alkaline phosphatase levels are low. So if you have a ALT AST ratio of more than 5, then it indicates more of a hepatocellular injury. If this ratio is reversed and you have a higher alkaline phosphatase level more than twice the upper limit normal, and the ALT to alkaline phosphatase level ratio is less than 2, then these are predominantly cholestatic injuries. And if you have a mixed type of picture where the ALT is also high, the alkaline phosphate is also high, and the ALT-AST ratio is somewhere between 2 and 5, then these are called as a mixed hepatocellular cholestatic kind of mixed injury. Clinically, they may be mild, moderate, they may be severe, they may present as acute liver failure, or of course, they may be fatal if they are very severe, where patient may progress to complications and death, or be a candidate for liver transplant in order to ensure that the patient survives. The mechanisms are generally hypersensitivity reactions, and as I said, they may not be really predictable in whom will or whom will not develop. Some people have more of a cholestatic picture, especially the elderly ones, and the younger individuals, or especially women in particular, have been known to have a more hepatocellular and an acute kind of presentation. There are other risk factors besides age and female sex. If you have associated malnutrition, or if you have associated history of alcohol consumption, or an underlying liver disease, or patients who have liver cirrhosis or chronic hepatitis of other etiologies, patients who have NASH with race transaminases and have developed tuberculosis and need to be on AKT. So these are the other risk factors where one needs to be very vigilant as to whether the patients are tolerating AKT or not when they are started on these drugs. Most patients who come to us with AKT-induced hepatitis are already on the combination of INH with rifampicin with pyrazinamide. So these three are the agents which are causative, and out of these, whatever is causative, the first thing to do is to stop all three, and then later on, once the patient improves symptomatically, their enzymes normalize, one can give a re-challenge of these drugs. And there are particular protocols on how re-challenge with AKT is to be started. So you might start with rifampicin, add up isoniazid at a lower dose, then increase the dose to normal. And if the patient still does not develop hepatitis, you monitor them very carefully, and then you can add up the other agents as the days go by if the patient tolerates the AKT quite well. What about treatment? As I just mentioned, the first thing to do is to stop causative anti-tubercular agents. You need to put these patients on alternative AKT medications. So you may need to switch over to streptomycin injectable, or add up the quinolones in addition to continuing ethambutol. So these are the three agents which need to be started. And then, as I said, you can re-challenge. If the re-challenge also doesn't work, then you might need to go to second line agents for the treatment of these patients. When the patients do come to you with a hepatic illness, you need to, in addition to stopping the drug, you need to give supportive therapy. You can give antioxidants. Yeah, if the patient's symptoms are mild, then maybe just something for the nausea, vomiting, supplementation of nutrition, and maybe supplementation of B complex agents, along with antioxidants like glutathione or acetylmethionine, or other supportive kind of medications. Most of the times, if they're mild symptoms, they should do well. If they have more severe symptoms, patients may need admission, especially for monitoring as well as for treating their symptoms earlier and better. If they're not able to tolerate much, then they need to be on IV fluids. If people are or patients are going into liver failure, hypoglycemia, acidosis, these are things that need monitoring, and they should be promptly treated in addition to continuing the other antioxidants. And if the patients do fall into King's criteria for acute liver failure, either acetaminophen or, in this case, non-acetaminophen criteria, then if the severity is or the MELD scores are an indication, then these may be candidates for considering an urgent liver transplant, and that may be the only hope and the only the treatment modality that can be offered to these patients. Otherwise, they may not survive.